I think always surveillance. I think once you and your physician establish that you have a suspected diagnosis of endometriosis and you've begun medical therapy, I think there should always be a surveillance of how that patient is doing, that their symptoms continue to be controlled, that their priorities are being met, so that if it's simply pain control, that as time goes by, the severity of their pain is not worsening, and that the current medical modality that you're using is continuing to work. I think at the point that it is no longer effective, then certainly there can always be a change in the medication therapy. For instance, if you start with a birth control pill and that's no longer controlling their pain, you can try a continuous birth control pill. If that's not working, you can always switch to perhaps an injectable progestational agent such as Depo-Provera. I think if you get to a point where that perhaps is not as effective, then you could switch to something like a GnRH agonist, which is an injectable medication that suppresses hormone production and thereby suppresses the endometriosis. I think when medications are failing a patient, whether you've tried one medication or multiple medications, the definitive gold standard for diagnosis of endometriosis is identifying it visually, but also biopsying and having histopathology confirmation that you are dealing with endometrial glands and stroma outside of the uterus. So I think that if medication is not working for your patient, then certainly you can consider a diagnostic evaluation for endometriosis. And in that same process, you can treat areas of endometriosis that you find surgically by removing those areas.